Sounds good. Welcome to the ASRA RAPP podcast. I'm your host, Raj Gupta, with my co-host, Eric Schwenk. We're trying something new today. We're trying a video podcast on Google Hangout to see if we could maybe expand the appeal of this podcast to seeing our faces so that when you meet us in person sometime, you can actually know who we are. And we have a couple of wonderful guests with us today. And there's a little bit of self-promotion going on because I picked somebody from my institution, and Eric's got somebody from his institution, and we're going to be talking about papers written at our respective institutions. We're going to be talking about perioperative ketamine use and what the pros and cons of that are and how you might be able to implement that in your institution. So my first guest is Chris Sobey. He's an assistant professor of anesthesiology at Vanderbilt University School of Medicine. He's also part of the Division of Pain Medicine. He's also our fellowship director for the Pain Medicine group. How are you, Chris? Thanks for joining us.
I'm doing great. Thanks for having me on. I appreciate it.
And then we've also got Jaime Baratta, who's a clinical assistant professor of anesthesiology at the Sidney Kimmel Medical College at Thomas Jefferson University. These titles are getting very long. I'm getting tongue-tied trying to pronounce everything. And Jaime, how are you? Thank you for joining us.
Thank you for having me.
And then, of course, Eric is an assistant professor of anesthesiology at Sidney Kimmel Medical College at Thomas Jefferson University as well. Eric, how are you?
Good. You got it right that time.
Yeah, I know. I'm gonna get this right eventually. About episode 10 or so, I'll get it all perfect. And then, of course, I'm also at Vanderbilt University. I'm associate professor of anesthesiology here at Vanderbilt. And before we launch into our topic today, I do want to talk about a couple of things coming up for ASRA. The ASRA Fall Pain Meeting is coming up pretty soon. It's November 17th through the 19th in San Diego. Go to ASRA.com for details, but the registration is open. I think it's going to be a great meeting. It's all about chronic pain management and pain medications, and I think that'd be awesome for all those people that are interested in that topic. There are still open deadline for abstracts. If you want to contribute an abstract to the meeting, that deadline is September 7th, so that's coming up really soon. So if you've got some good material to present at the meeting, make sure you jump on ASRA.com and go check that out. The other thing I want to mention is there is an early bird deadline for the ASRA ASA Combined Ultrasound Guided Regional Anesthesia Education Portfolio Cadaver course that's going to be held in Chicago. The deadline for that is August 2nd. So again, go to ASRA.com, go check out the information about that cadaver course, which I think is a great opportunity to learn ultrasound skills. So with that out of the way, I do want to introduce our topic today. And the impetus for this topic came from two papers that were published in Regional Anesthesia and Pain Medicine. The first one is a paper by Eric and Jaime and their group up at Thomas Jefferson. And I'm going to see if I can pop it up here so you guys can see it. Is that showing up for you guys?
Yes.
Yep.
Awesome. So this is the adverse drug effects and preoperative medication factors related to perioperative low-dose ketamine infusions. And then we had conveniently, Dr. Sobey and our group here at Vanderbilt, a few of my colleagues here, wrote an editorial called Postoperative Ketamine, Time for a Paradigm Shift, and in that same journal. And we're going to be talking about both of these articles. So we're back to me. So I want to start out the conversation and talk a little bit about why ketamine is a good perioperative pain medication and why is it different from opioids, just to kind of get a baseline conversation. Eric or Jaime, you guys want to start that off?
Well, I think, it's definitely really important to talk about ketamine, especially now as we're in this opioid crisis and trying to minimize opioids and the effects and for the treatment of both chronic pain and perioperative pain. And the thing about ketamine is, which we've seen both, in our paper that you just mentioned, it's very effective as an analgesic, and also it's been shown to reduce postoperative opioids as well as pain after surgery, while also having fewer adverse drug effects. Most significantly the respiratory depression associated with opioids.
So
yeah, I agree.
Go ahead, Eric.
Yeah, I mean, I'm just kind of seconding mostly what she said. I think the respiratory depression is the kind of the big one that most people know about, but I think some people don't always think enough about. I think the stigma that ketamine has due to its, I don't know what it's due to, if it's due to just its street association or its labeling as an anesthetic. I know those are things we can touch on, but I think the connotation that goes with it being a dangerous or more risky drug are mostly not warranted, and I think it really has a lot of good properties for post-op pain control over opioids, and I think that's the impetus of why we thought that it was worth describing it in the paper.
And Chris, as far as people who haven't used ketamine, what do you think is really unique about ketamine as opposed to what they're familiar with using, morphine, Dilaudid, or other oral opioids for pain control, for post-op pain control primarily, but then also in the chronic pain area?
Right. So, in terms of chronic pain, that's where I think my experiences in seeing these patients in clinic, coming off of larger, moderate to large surgeries, and sometimes even small surgeries, who are continuing on opiates long term, and struggling getting off these medications. And what really differentiates ketamine from opiates, not just in terms of the mechanism of action, but that you see this hyperalgesic effect even with a short exposure to opiates. We used to think it was time dependent and dose dependent, but you're seeing even patients with one or two exposures, in some recent articles that have been published, getting this hyperalgesic and allodynic response to different sorts of sensations, either whether it be a painful sensation or even normal sensation. And that's something that we really need to consider when we're deciding what medications these patients should get in the hospital, get when they're going home, and then what they're getting by their surgeons or their post-operative provider on discharge.
So when you see patients in the pain clinic, are you seeing patients having similar issues with dependence with ketamine if they've been exposed to that?
Well, I think this has a lot to do with the availability of the medication itself. PO ketamine is not something that is, or by mouth ketamine is not something that's prescribed on a frequent basis. It's mostly reserved for various individuals, cancer pain patients, individuals that can't tolerate opioids for whatever reason, and it's not necessarily a mainstream um, prescribed medication. And most pharmacies don't carry it regularly as well. The other thing is that most providers aren't comfortable prescribing PO ketamine, um, and as most providers in the hospital are not necessarily as comfortable using IV ketamine. But I have never seen one patient come in that's a chronic pain patient that has had a dependence issue with ketamine. That's not something that I've seen in my practice, or I can say in my fellowship that I've seen as well. So I really think that we need to focus more on the opiate reduction part, because that's really what's having a societal impact right now. 4 out of 5 I described this in my editorial, but 4 out of 5 heroin users right now describe starting their addiction process with uh, legal pain medication, and it just persists and kind of becomes more of an issue with their tolerance, and they need more and more, and the hyperalgesic effect, like I talked about earlier, becomes more of an issue as well. So I really think that we need to reorganize how we're thinking about post-operative pain treatment in general, and try to reduce our reliance on the opiates.
If I could just chime in just real quick, just before we completely leave the oral ketamine topic. I don't know what your experience is, Chris. I mean, we don't really use oral ketamine much at all. I mean, perioperatively, there's really no use of it here. We're using intravenous infusions, sometimes some boluses, but we're more or less doing intravenous infusions on the medical floors and in the OR post-operatively. And I'm just curious if you have had any issues with the absorption being erratic or inconsistent benefit being seen from the oral ketamine that you've used.
I've only used it a very select few times in the pain clinic. I've never used it in the hospital before. So, like I said, most of the medications that, I'm sorry, most of the patients are not necessarily candidates for PO ketamine. So I would say that absorption issues or excretion issues are anecdotally are not things I'm familiar with, but I don't I think it's a bigger issue than that. I think the accessibility of medications in general, once they're promoted in the PO form, is really the impetus for misuse. The reason why the opiate epidemic has started is because of the now proliferation of PO um, opiates during the 90s and early 2000s, and the availability. They weren't as available before then, so you didn't have the same consequences and proliferation of the use. So I'm not I don't necessarily think that ketamine is as dangerous of a medication um, as opiates are, specifically with the respiratory depression problems. But I am concerned that if we do start using it in an outpatient setting or using more of a PO setting, that it has more risk of having an abusive quality in that sense.
So that kind of I'm jumping ahead to one of my questions I have for later, which is part of what's affecting ketamine use is legal stipulations that are different in different states, different designations of ketamine as a anesthetic as opposed to an analgesic, as opioids are categorized, and that restricts who can give it and how it has to be administered, particularly with the IV medication. Um, are we dealing with a situation that relaxing those laws or changing them would be better, or is that just creating a new problem if we do that? Eric, what do you and Jamie think over there? I mean, do you think we need to expand its use to allow it to be used in more places like the floor, away from the ICUs, away from, um, administration by sedation nurses and things like that?
We already are able to use it on our general medical floors. We do luckily have a very good pain service that almost has 24-hour trained acute pain nurses on hand to be evaluate patients for side effects, and they will adjust the rate, increase and decrease the rate accordingly. Only physicians here will do boluses of ketamine, so we don't, our floor nurses will hang it, change the bags. They won't really titrate it in any way. But I do think we're fairly liberal in our how it's handled, and not limited to the ICU.
And I think that if our paper showed anything, it definitely showed that the infusions can be done pretty safely in a general medical floor setting. I mean, these patients did not get telemetry, they did not need ICU settings, they did not need additional monitoring or any precautions. Really, the main thing that goes along with our ketamine infusion protocol is that patients will have a benzodiazepine ordered PRN for treatment of side effects. And as Jamie mentioned, there's always uh, more or less 24-hour nursing coverage, and the nurses do have additional training. We do have a PowerPoint that's been created that does go out to the majority of the floor nurses who will take care of some of these patients. So even though they're not directly changing the ketamine infusion rates and doing that kind of thing, they're at least generally aware of some of the side effects and the problems that can happen with it. And I think when you have those things in place, it just takes a little bit of a institutional cultural change to get used to doing something that's kind of been seen as taboo or maybe controversial in the past. And once people see some of the benefits, I think that it's starting to prove itself.
So quickly, just to follow up on that, how much resistance did you get on implementing this kind of protocol, and who did you get the resistance from?
I
We
mean, to
don't.
be honest, that kind of outdates us.
Yeah.
I mean, we're not in that. We've been doing it for a while. Gene Viscusi's really kind of brought the protocol and ketamine infusions on the floor to Jefferson, so that goes back a while. I mean, I think it's at least probably 10,
Yeah,
maybe
at
10
least
years.
at least.
Wow.
Now, what he faced when he got here, I can't really specifically speak. I mean, we'd have to, I think, find out from him. But I know it's been pretty acceptable for as long as I've been here, even as a medical student, going back to like 2006 or 7.
So, Chris, I know I've dealt with this a little bit, and now you're jumping into those shoes here at Vanderbilt. What kind of hurdles are you facing trying to get expanded ketamine use?
Well, the hurdles seem to be more legislative than anything else at this point. I was always under the impression that ketamine was restricted because either the nurses didn't feel comfortable with it, or the people that ran the hospital didn't feel comfortable with kind of liberalizing the accessibility. But the more I dug into the topic, because I did feel, as Eric and Jamie have showed, that it would be incredibly beneficial. It's more of a legislative issue. In the state of Tennessee, it's labeled as an anesthetic. It's not given the same freedom in terms of how it's administered in our state, and I think that it's going to have to be a push from our physician groups here and hospital groups here to liberalize those laws. And if there's some concern about adverse events, aside from the information that Eric and Jamie's paper showed, that that's not really a large concern, but the the fact that we could restrict it to a lower dose and still minimize those effects is really important, and something that would would be very helpful in the perioperative setting. So that I really push for all the hospitals to reconsider how easily accessible opioids are, higher dose opioids that can have catastrophic consequences versus a medication that, if you do a PubMed search, there's really no catastrophic mortality from ketamine overdoses intravenously in the hospital. So it's something that seems kind of silly at face value, but we should really reconsider how we're treating these patients.
So,
Just to quickly follow up, if you look at the Leskowski review that I had included, they mentioned in the results that there were no serious side effects, death, loss of limb, organ in the entire review, and that was a pretty large review. So I think that just provides further evidence to back what Chris is saying. There's really no evidence to show that in a hospital controlled setting that ketamine has caused any serious injuries, and I think that it's pretty obvious that the number of deaths from opioids well exceeds, the number that would be associated with ketamine.
this is the paper you're talking about.
Yes,
Yes.
it's on page 918. I think it's page 8 of the PDF.
And if you consider that we have, over 165,000 opiate-related deaths now, more than motor vehicle accidents per year, I mean, we really should be looking at the cause of um, this issue more seriously.
Now, showing that ketamine could actually cause a reduction in those events is something that has not been done yet, but it's something that's kind of interesting. If somebody could actually show a reduction in opioid-related adverse effects in respiratory depression, other effects like that, I think that's a potential area for research with ketamine as it stands now.
So, one question I have though is that, this is where I always get stuck, is that we've assumed that what we've been doing is fine, which is that we put a bunch of people on high dose opioids with IV PCAs or large dose oral opioids, and we've all come to accept that set of risk factors. That some of those patients are going to get really sick to their stomach, some are going to get respiratory depression, some may have respiratory arrest, and that doesn't even include the downstream effects that Chris was mentioning earlier about hyperalgesia and opioid dependence. But the resistance to change is always such a big hurdle that we fear the unknown as opposed to fearing what we're doing right now. So Eric, you guys at a place that has been doing ketamine infusions for a long time, and I'm guessing there's also patients on IV PCAs. Do you, at least anecdotally, do you or Jamie, do you guys see a clinical difference between those categories of patients having major adverse events like respiratory events?
You want to
I think,
touch on that?
I mean, anecdotally, I definitely would say that, utilizing ketamine, decreasing, the amount of opioids that they need for adequate pain control, I would see that decreased, side effects. More commonly, decreased nausea, vomiting, pruritus, as far as respiratory events, likely, I don't know that I could say that, I definitely have noticed that. In reviewing it, sometimes the problem is that, especially for us patients on the pain service, are most often on ketamine as well as, PCA, versus the patients that may be having these, respiratory depression, RRTs or codes with certain things from the opioids that are on just PCA, aren't on our service, that we may not be, seeing and been able to compare. So although I would assume that that's the case, I don't think that I have enough to prove that.
Right. That being said, I think the number of times we've used Narcan on the pain service has decreased over the past 5 to 8 years. Now, there's other factors, like we're not using epidural morphine anymore, but I do think that the expansion of ketamine potentially sparing some of the opioid from the PCA, I think, may be playing a role in that.
Chris, do you know if we're looking at any of that data here at Vanderbilt?
Well, I don't know specifically if we're looking at ketamine in itself, but I do know that our opioid utilization in on the ERAS protocol patients, the enhanced recovery after surgery protocol patients, has significantly dropped, and I'd have to ask one of my co-contributors in my editorial, Adam King or Matt McAvoy, because they would probably know about this. But definitely anecdotally, I can't remember the last time we had to use Narcan on a patient, even without having access to ketamine on the floors, because overall, just the whole gestalt about reduction in opioid utilization has really empowered our service to improve patient outcomes, to get patients out of the hospital a bit faster, and have more of a reliance on either multimodal analgesia or regional analgesia as options. And in that sense, I definitely think it's improved our safety profile. But that would be a great data pull to do.
I think that's important, with ketamine, just to remember that, it's not just ketamine and opioids, and to remember the other non-opioid adjuncts that are really multimodal. Analgesia is really where we make these improvements in decreasing our reliance on opioids and those opioid-related side effects.
So,
Yeah, I agree.
So Eric and Jamie, you guys are, like I said, you guys have been doing this probably longer than we have over here at Vanderbilt, but your study was on spine surgery patients, so I know you're using ketamine for those patients, but who is this good for? Who should we be thinking about ketamine for? If people are out there starting to explore ketamine use, who should it be for, and how do they get started using it?
I think first, the people that you want to really, are your first group of people you want to look at for treating ketamine is, identifying people that, are opioid tolerant, as well as, presenting for some type of surgery that's expected to have, more severe pain post-operatively. Simple, smaller surgeries, like in one of the papers where they found that, head and, things like tonsillectomy or, some sort of head and neck surgery doesn't tend to have, is more associated with minimal pain, and the ketamine won't have as profound an effect. So I think, why we chose spine surgery, especially with looking at the opioid tolerant patients, which are more likely to get ketamine, is because that surgery is more painful, more likely to require larger dose of opioids to get adequate pain control. So I think that's where you start.
I think on our service, our pain service in a given week, definitely the largest volume of patients will come from spine surgery. Now, part of that's because we do, over 2,000 some spine surgeries a year, so we're a ridiculously high volume center. But even beyond that, a lot of those patients, a good percentage, will be taking opioids and are opioid tolerant going into surgery. So your population already is a population that's at higher risk to have higher levels of post-operative pain. Like going back to the Laskowski review, they suggest that from the review, pain surgeries that have an anticipated pain score of 7 out of 10 or greater are the ones in which ketamine will probably exert the biggest bang for the buck. And I can tell you, our opioid tolerant patients, like I'm sure yours are going to start off with a baseline of 10 pre-op if you ask them. So 10 is only going to go up to a 10 post-op. So those people are clearly at high risk. So the spines, there's a lot of those in the spine surgery population. But in addition, I think any painful surgery, I think thoracotomy, major abdominal surgery, some of these bigger flap procedures that we do with our breast and ENT surgeons, orthopedic surgery, knee replacement can be painful. We have a orthopedic oncologist who does, huge tumor resections. We'll use ketamine, and those people, they're often on, huge opioid doses. I think all those surgeries are usually what we're mostly looking at. And our side effects data from the paper actually is not just spine surgery, even though the other data are from spine. The side effects kind of represent all, so you can I think generalize that a little bit more to other surgeries.
And how are you dosing the ketamine? I know everybody's got a slightly different dosing strategy, and you mentioned titration up and down to a certain degree. Or where, just to give somebody a tip on how to get started, if it was as simple as you could make it, how would you dose it?
I think it's honestly, it's not a set protocol for intraoperative, because usually it's started intraoperative by the anesthesia team in the OR who recognize this patient might benefit. But a typical case, we might do a bolus of 0.5 milligrams per kilogram in the operating room, start an infusion somewhere around 0.25 milligrams per kilogram per hour. So for your average 70, 80 kilogram patient, that it's going to be somewhere in the 15 to 20 milligrams per hour infusion rate, and that'll be continued postoperatively. Now that's specifically for post-op analgesia. We have other patient populations, migraine headache patients will treat differently and be much more aggressive. We'll have patients who are getting ketamine for sedation in the ICU on ECMO, and they will be much more aggressively treated. But for your kind of chronic opioid patient who comes in for back surgery kind of situation, I think that's at least a reasonable starting point.
And Chris, I'm letting you speak here for our institution. Where do we start here at Vanderbilt?
Well, we put together the spine protocol actually about a year ago that involved using ketamine in the in intraoperative and postoperative part, and specifically for patients that came in on opiates preoperatively. I think that right now we're limiting our ketamine use mostly to spine in patients that have high opioid tolerance to begin with. I really think we should consider expanding it out to cases that Eric was referring to that have that moderate to high risk of severity of pain afterwards. And then there's going to have to be a lot of legwork in terms of the legislative actions and trying to convince our state senators and representatives that giving us a little bit more access to the medication on the floors. We're still keeping it in the hospital, but having it be accessible on the floors while the patients are being monitored is something that is actually going to improve patient safety and not put a burden on it. So that's going to be part of the process. One question, or actually one comment and one question I had for our colleagues, but the Laskowski review really was very. I had read it before your article, guys, but it shows that the importance of using ketamine is not necessarily preoperatively, before incision or after incision, or it doesn't really matter when to give it, and it doesn't really matter if it's an infusion or a bolus. It states pretty clearly that its benefits supersede all that, which is really nice to know. But in terms of y'all's experience, since you've had more than us, do patients have more adverse outcomes, or I wouldn't say adverse outcomes, but adverse events happen when they have boluses versus infusions?
I don't. I mean, we do so frequently. Our patients, are continued on infusions postoperatively, and based, on their assessments, if they're having increased pain, they may get a bolus with the increased infusion, and we really, haven't noticed any difference in patients that are getting boluses which versus patients that are just on the continuous infusion without any boluses. And as far as adverse events, every patient's different. How much of the CNS excitation kind of symptoms such as hallucinations and visual disturbances, and it's unpredictable who might have those. So we really haven't seen that, and just at least anecdotally from what I've noticed.
We do, I would say we do tend to shy away from the bolusing postoperatively a little bit, except in kind of select patients for maybe, a patient having a wound clean out or a patient having a dressing change, use it in that kind of situation. But to routinely give patients boluses on demand, we've kind of shied away from it. Creates a little bit, it creates a little bit of a situation where you could potentially get into drug seeking kind of behavior for the euphoria and so forth that you can get from that. So kind of like having a patient get a PCA rather than getting nursing boluses of larger doses. I think that keeping a little more even, except in certain situations, so it tends to be what we do.
All right, so I like to always finish off with a little bit of a more challenging question, and I'll shoot this off to Chris first, and then to the other guys over at Jefferson. So you mentioned earlier that if ketamine, oral ketamine in particular, were more widely available, that it probably would become a drug of abuse or at a higher rate than it is right now, because we don't see it that often right now. But given the problems that we have with opioid abuse, if you had to pick a drug that was going to get abused, would it be better if ketamine was a drug that was being abused more commonly than what we're dealing with right now? Because we know that there's certain people that have a tendency to abuse whatever's available on the streets or on the markets. Do we pick ketamine as the lesser of the two evils?
I think that's a fair statement and a fair question. The You're kind of asking
Thanks for
which
taking
way
that
do you
one
want
first.
to have do you want to die by drowning or die by hanging? I mean,
Right.
they have problems either way. Definitely in terms of the risks involved, ketamine is a less riskier drug of having severe mortality or morbid conditions thereafter. So in that sense, I would say yes. But I think the bigger societal implication and question is how are we as Western countries really managing our pain, and is it different and better than how more different cultures are managing? We use a preponderance of the opioids in globally. I mean, we're using 99% of all the hydrocodone that's produced in the entire world is used in America. And is that really because we're in more pain? No, it's because it's more accessible, and because we have a different mentality on what pain relief should look like. And until we kind of realize that a certain amount of pain is acceptable um, in a recovery or acceptable in a certain pathology, and it shouldn't be the expectation shouldn't be 0 out of 10 pain. We're gonna keep searching for the next magic pill that's gonna fix us, or magic injection that's gonna fix it, because and that's not a realistic expectation. And I really think it's a cultural change in that sense. I mean, hopefully that we have a pharmaceutical company that comes up with something that's not addictive and can prevent postoperative pain. But in the interim, I think we really should think about talking about realistic expectations with patients.
Yeah, I think that's a really great point because we really have to help educate patients and change their perspectives as far as pain. And there may even be value to trying to identify those patients that may be higher risk, more sensitive to pain. Maybe there's value in some sort of cognitive or behavioral therapy preoperatively to try and decrease that incidence and that the way they think about perioperative pain or pain in general. So we definitely have to really kind of change the expectations and change the way our patients think, as well as how physicians think. That we need to take all the pain away and find some pill to do it.
Yeah, in terms of saying it would be better to have people abuse ketamine, I don't definitely can't go that far. I mean, I think the abuse is going to be bad regardless. But I think, I mean, just statistically and based on the science and based on the data so far, I mean, it certainly would be safer. But I think the abuse is certainly going to be a problem, and it introduces other problems. You can get liver toxicity from ketamine, and you may become violent and act because of your hallucinations. So that's like a whole other, there's different problems with each medication. But in a hospital controlled setting, things can still happen with opioids, whereas I think with ketamine, it's becoming more clear that they're very rare events.
Well, I'm disappointed in all of you guys for giving such a nuanced and thoughtful answer. I was trying to bait you guys to something a lot more controversial, but that was all reasonable. I think that this is a difficult topic. I think that we're all looking for good solutions, and these are patients who are suffering. There's no doubt about that, and we're all trying to find a better way to help them through their suffering. Unfortunately, there isn't just one size fits all solution to all these patients, and I wish there were, but there's still a lot of hard work to do. So with that, I'm going to wrap up. I want to thank Eric, Jamie, Chris.
Thank
This
you.
has been a great
You're
conversation. This is the ASRA RAPP podcast. You can find us on iTunes. You can find us uh, through the ASRA.com website. And now we're going to try to keep some of the video portions of this available on YouTube as well. So we'll try to have all the links up on ASRA.com so you can go find us, subscribe to us, tell your friends, and of course, wherever you can, rate the podcast or leave comments that lets other people know that this is worth watching or listening to. That helps us out, spread the word, and we'll keep you posted. We got another great one coming up next month. We've already got that one in the works, and I think that's going to be a real interesting topic. So we'll keep an eye out on us on Twitter and stuff, and we'll let you know what that is when we get there. But again, thanks a lot, and we'll see you guys next time.
Thanks a lot, guys.
Thanks very
Thanks.
much.
All right, bye.